Okay. So I was all prepared to say like, oh, did anyone watch the video? And you all would have shaken your head yes, and then I would have been like, oh yeah, well, there's only 14 views on the video. There's like 39, which doesn't make sense. Right. So I'm like, there's not even 40 something of you guys to watch it. So watch it twice. I am so proud, so proud. My heart grew 3 times its size. I thought you made a comment like, wow, I was so proud. So proud. That's great. Make sure you smash that subscribe button, like, comment. No, you don't have to do all that stuff. I don't make any money off that stuff anyway, so it doesn't really matter. Huh? Maybe if I decide to do my own side series. Yeah, I just need time. I need time, right?
You are going to be famous. You're going to be the famous pharmacist.
Listen, I'm famous enough with you guys as it is. That's all I need. Anyway, I apologize about missing class. I think that might have been the first time I've ever had to cancel. It was very fortuitous because there was only a 1-hour lecture, and it was spring break this week for Nova, so my body decided that now is the time to shut down for once yearly sickness. It was fine. I was not that sick. I just sounded really awful. I'm still not 100%, but it's fine. If I get a little phlegmy, just bear with me as I hack and cough. So anyway, so is there any questions from the video? We kind of finished up the talking about hepatitis, and we moved into talking about diabetes. We talked a lot about insulin. Any questions on that so far? So remember the different types of insulin that there are, the different characteristics as far as onset, duration, all of that. We're going to talk about how we're actually dosing this stuff in just a little bit. That'll make more sense. But getting into the complications of insulin, and again, insulin is one of the most high-risk medications you're going to possibly be dealing with on a routine basis. You can absolutely kill someone very easily with insulin if you're not careful, if they're not monitoring it effectively or appropriately. So hypoglycemia is going to be the main reason for that, right? So again, too much insulin, you're going to get hypoglycemia. That's just a known thing. That becomes a big problem, especially in hospitals when you have, especially these type 2 diabetic patients who are extremely insulin resistant. They need really, really big doses of insulin, right? So anyone know like a typical dose of like an insulin might be like kind of a normal range? So it might be like 3 units, 4 units, maybe up to like a dozen units or something. It all depends on how insulin resistant these patients are. And so which do you think would require bigger insulin doses? Type 1, type 2? Type 2, absolutely, right? So those are the people you can see getting up to 30, 40, 50, 60 units of insulin. So it becomes a problem where you're giving such big doses, you might need higher concentrations. And so that's where you maybe have to switch from that U100, which stands for 100 units per ml, to U200, U500. Anytime you're mixing up concentrations, you can run into big problems. And there's been cases of people becoming very hypoglycemic from getting the wrong concentration of insulin or the wrong type of insulin. So you have to be really careful. And again, what are those signs and symptoms of hypoglycemia you'd be looking for? Sweating, some dizziness, fatigue, you get tremors, tachycardia, confusion. What can it ultimately lead to? Because again, what organ is going to be taking the biggest hit there? The brain, right? So you can see seizure, coma, death, right? Those are always the big things you're always obviously concerned with. That's where it can kind of lead to. And in fact, when you're dealing with a patient who is presenting with altered mental status from an unknown reason, what's one of the first things you're going to check? Check the sugars, right? You're going to do it because, again, that's easy. That's something you can do at the bedside. You can check your glucose. If it's low, guess what? How do you treat it? Give them sugar, right? That's it. That's all you got to do. I mean, don't kiss the patient, but give them dextrose intravenously. That's probably the more accurate.
Can you answer this? Because why would you give the
glucagon?
So yeah. So would you give them like D50 in that scenario?
We'll talk about that. Yeah. We'll get into treatment of that in just a little bit. Yeah. So it's okay. It's a good foreshadowing of what we're going to get to, right? So we know the side effects. We got to know how to treat them too, right? Anyway, so yeah. So again, I always think about like when's the last time you were hangry? Like that's kind of what like hypoglycemia feels like, right? You're just kind of irritable. You're just getting confused and you're tremulous. Now, is there any drugs that maybe be able to mask the signs of hypoglycemia? Beta blocker. Why do you think that is? Something with the receptors. I like that. It's very vague, but it's still accurate. Good. But to get into more detail on it, if you think about it, like what is your body doing when it senses it's hypoglycemic? How does it respond to that? How does it try to get blood sugar back up? Glucagon's one thing, right? So that will stimulate glycogenolysis and gluconeogenesis in the liver. What else can stimulate that? Cortisol can do that as well. Yep, that has glucocorticoid-like action. What's a really fast way to do it? sympathetic nervous system, right? Just like when you have to go run a marathon or something, you need blood sugar, right? So again, your body's going to stimulate the sympathetic nervous system. It's going to cause those beta receptors in the liver to respond by producing new blood glucose. So that's where you also get the tremulousness, where you get the tachycardia, where you get the sweating. Now, if I gave you a beta blocker and all of a sudden I'm blocking up all those beta receptors, you mask the signs and symptoms of hypoglycemia. You may be hypoglycemic but not know it based off the characteristic things you'd be looking for. Okay, so that's why you have to be really careful with beta blockers in diabetic patients. I mean, mask those signs of hypoglycemia. Okay, just something to keep in mind. Now, again, how many type 1 diabetics do you see on beta blockers? Not as commonly, but a type 2 patient with a history of MI, history of all the other things, right? Yeah, so you can definitely see that combination happen pretty frequently. Anyway, so we'll talk more about treatment of hypoglycemia in just a few minutes here. But you can also have some immunopathology. So again, we are injecting proteins into the body, so you can see issues with that. One, you may actually see an insulin allergy, so an actual IgE-mediated reaction. If you ever see someone who's allergic to insulin, you may think that's one of those silly kind of reactions, because like, well, you can't be allergic to insulin. Like, your body would just be reacting to yourself all the time, right? Oftentimes it's not the insulin, but it's something in the insulin, right? So it's something that's contained in it. Just like if I ever see someone with an allergy to epinephrine, I'm like, well, you'd be dead if you had an allergy to epinephrine, but it's usually a preservative that's contained within the epinephrine. So if you ever see a sulfite-free epinephrine, that's what it's used for, right? But again, someone has a reaction after they got epinephrine, so what gets on the chart? Epinephrine allergy. Okay. Anyway, so insulin can do the same thing. So for instance, you can have a protamine allergy to cause you to react. So if you got a dose of NPH insulin that has protamine in it, and again, how did that one act? Was it short-acting, long-acting? Good, is it more intermediate? It's like a Q12-hour kind of dosing insulin. You would see that they would have a reaction from the protamine, not the insulin itself, right? So that's one thing you might want to worry about. And again, you treat that just like any other anaphylaxis, anaphylactoid reaction, right? You can actually develop resistance against the insulin itself, so you'll develop IgG antibodies that will actually go in and bind up that insulin that will make it less effective. So again, some of these patients, you're like, well, are they getting more insulin resistant? Is it because the insulin's less effective? This could be one of the reasons for that, right? Once you know the patient's being compliant, they're taking it like they should, but it's just not working right. This could be one of the reasons there. Okay. Also, you have some injection site reactions, of course, because we mentioned these have to be injected. There's one inhaled form that's not going to be as common. And so usually if you're, and of course, where do you keep insulin at? Where do you store it? Most of the time you're going to keep it in the fridge. Why do we do that? It's a protein. We want to keep it in its normal form. If you expose it to heat, that's where it's going to be a big issue, right? So again, it's another question like, okay, well, the insulin doesn't seem to be working. Well, where are we storing it at? Well, I left it on the dash of my car and it's July. Okay, that insulin's not going to be working very good anymore, right? Because again, this is Florida, it's not Canada where that might be okay. You will find that some insulin, most insulins can be kept at room temperature. Once they are open, they will usually have a certain life expectancy on it at that point, usually 28 days or so for insulin. So again, once we pierce a vial of, say, Lantus or Humalog or something like that, usually 28 days afterwards, it's going to be no good at that point. Usually from a sterility issue more so than a stability issue, right? You guys know the difference between the two. Sterility just meaning keeping all the bugs from growing in it. Stability just meaning the drug is actually still working. So that's one thing, right? So consider how they're actually storing it. But when you inject a cold product like that, you can see some pain associated with that, some injection site reactions. So oftentimes we'll have them warm it up in their hands, just kind of roll it. Now again, you don't want to be too vigorous with that, because what happens when you start shaking the proteins? They foam up, and that's when they foam up, that means they're denaturing, they're coming out of solution. You don't want that, right? So any protein-based product, you cannot shake them, because they'll start to foam, and that foam is no good, right? It means the drug's not actually in that solution you're injecting. So again, just gentle rolling, we'll have to warm it up a little bit, and that will make it a little bit more tolerable there, okay? You can see lipodystrophy if you keep injecting to the same site over and over and over again, so you do want to rotate around the abdomen. That's going to be effective there. And then the other thing to note is weight gain is going to be a very common thing you see with patients on insulin. You know it's going to happen, you just got to be aware of it, right? Not a problem for a type 1 patient who are usually pretty thin to begin with, because again, why do they get weight gain? Because insulin, so what does insulin do? It's anabolic. What does it do though? Puts the glucose, puts amino acids, puts all the fat, puts it into the cells, right? That's why it's an anabolic hormone, because it helps to stimulate growth, right? Just like you ever see bodybuilders, sometimes they will abuse insulin because it's an anabolic hormone, right? Because it's going to help to shuttle more proteins and more amino acids into the cells to grow bigger, right? So because of that, you're going to get weight gain, right? We just know it's going to happen. So that's why you see type 1 diabetic patients are usually thin, because they don't have enough insulin to shuttle that glucose in, so they can't put on weight. For type 2 diabetic patients, though, most of them tend to be obese, right? So again, you're going to find that they will also be putting on some weight there. So when I show you a handy chart comparing all the different therapies for type 2 diabetes, you're going to find that one of the big concerns is, what is the weight, right? Because some of them are going to cause you to put on weight, some of them cause you to lose weight, some of them are going to be weight neutral. Okay, so that's a big key thing you might find, say, coming up on a test, for instance, right? Anyway, so just know that anytime you have insulin coming on board, you're going to gain. Okay, you can find that there's a lot of drug interactions here. Some things may increase the hypoglycemic effects of insulin, making it work better. You can find some things are going to make it work less effectively. It all just depends on several different factors, right? So for instance, things like thyroid hormone, right? Normally, thyroid hormone does what to the metabolism in the body? Stimulates it, right? So it makes sense if you're in a more stimulated, sort of more sympathetic sort of standpoint. It makes sense that you would have more blood sugar, right? It would make sense that the insulin would not be working as effectively in order to deal with that. The same dose would not be as effective. Anything that stimulates the sympathetic nervous system directly, like dobutamine or epinephrine, anything like that, just know there's a lot of drug interactions here to be aware of. Some things are going to make the drug less effective. Things will make the drug more effective, right? Things like anabolic steroids, because again, it's going to be shuttling all the glucose into the cells there. Things like beta blockers can be a problem because, again, what stimulates the liver to produce new blood sugar? Well, beta receptors are one of the ways it does that, right? Just because that's part of the sympathetic nervous system. Alcohol can also be a big problem with this, right? So I'll never forget when I was a young lad, I was in undergrad, and of course, you know, I grew up in Putnam County, so right, so I really wasn't exposed to many worldly type of views, meet different types of people. But when I got into undergrad, you get exposed to all these different people, you get to meet all these cool things, and so you know, I went to a party one time, right? And again, I was not much of a partier, so I was just kind of taking it all in. But I saw a student there, fellow student there, and she was imbibing. You guys don't believe this, but alcohol. Okay. And I was like, wait a second, aren't you a diabetic? She's like, yeah. And I'm like, are you supposed to do that? She's like, I don't know. Problem is that alcohol itself can actually make you hypoglycemic, right? It can deplete some of those glucose stores within the liver there and can actually make you hypoglycemic. And we already said, what are the signs and symptoms of hypoglycemia? But you're kind of like confused, and you're lethargic, and you're stumbling around. What does being drunk look like? You're confused, you're lethargic, you're stumbling around. So often you can't tell the difference between being drunk versus being hypoglycemic, and that can be a problem because if that person says, oh man, they had too much to drink, and they're passed out on the couch. Well, it could be because their blood sugar's 30 and they're actually not going to wake up from that. Okay, these are things to worry about, right? When we're dealing with kids in the poison center who get into alcohol, right? So we get that somewhat commonly, either whether it's mouthwash or whether it's something, you know, in the liquor cabinet or something. Yeah, a drunk toddler's pretty funny, but I don't know if it just because they're drunk or they actually get hypoglycemic because they don't have the same kind of glycogen stores like an adult patient does. So what do we tell them to do? Drink something sugary, right? Give them some fruit juice or give them some milk or something, so that way their blood sugar we know is not going to bottom out. Okay, so that way they do act a little loopy, probably because of the alcohol and not the hypoglycemia. So again, things to consider there. So what are our indications, right? So any type 1 diabetic patient is going to get insulin because we know they're insulin dependent, right? They're not producing their own insulin there. We will frequently use insulin as a preferred drug in patients with gestational diabetes. Right? If you need something, if you can't do it with diet alone, this is going to be the preferred agent because, again, it is the most natural thing we could do, right? It's going to be the most similar to what their body should be producing on its own. If you have diabetic ketoacidosis, now what is DKA? Yeah, exactly. Yeah. So this will happen with your type 1 diabetic patients who are profoundly insulin depleted, and you will find that they will have very high blood sugar. The high blood sugar is because they can't shuttle that sugar into the cells, and so what does your cells do for energy at that point? It starts to break down fat and also breaks down proteins, and that produces ketone bodies. Those ketone bodies also produce acids when you do that process, right? Because again, it's having to switch over to more, using lactate and things like that for energy. So because of that, they get very acidotic and they're very hyperglycemic. So how do we treat that? Give them insulin, right? So that's what we're going to do there. And so that's usually, in some cases, especially from the emergency medicine standpoint, how you determine someone is diabetic in the first place. They'll present with DKA because, again, it's kind of a slow process as they start to destroy those beta cells. Kind of on the flip side of DKA is going to be this hyperglycemic hyperosmolar non-ketotic syndrome. This is where you find it happens more with type 2 diabetic patients where they're insulin dependent, and maybe they are running out of it or they're not using it effectively or something like that. They get very, very hyperglycemic. You know, like a DKA patient may see like 300-400 blood sugar. And what's a normal blood sugar? Yeah, like 80 to 100, somewhere around there, right? These patients will be, you know, DKA patients, you may see like 300-400. These hyperosmolar patients, they can be like, you know, like 600, 700, 800, 1,000 in some cases, right? So they can be profoundly hyperglycemic. They don't get the same sort of acidosis as a type 1 diabetic patient does, but they're very hyperosmolar. They still need to be treated with insulin there. And then I also mentioned hyperkalemia. I think hyperkalemia could be treated with insulin. It shuttles it back into the cells, right? So again, one of the things you'll find is when you have someone with hyperkalemia, because again, what's the big risk with hyperkalemia? Arrhythmias, right? So we're about ventricular dysrhythmias occurring there, and so we will give them insulin and glucose, and that will help to shuttle that potassium back into the cell. That's a temporary fix, because again, what happens eventually? Once you lose that insulin effect, the potassium is going to come back out of the cell, right? So you got to do something else in the meantime, right? So either you put them on dialysis or give them some K-oxalate or something like that. But that's going to be a good stopgap in order to get the heart, you know, some of that pressure off the heart from the potassium standpoint. So lots of indications there. Now, when you're dealing with insulin for a type 1 diabetic patient, it's got to be tailored to the patient's lifestyle, right? So again, the goal is to give them something that's going to try to mimic the normal pancreas as best you can and not be so intrusive into their lifestyle to where you know, they're constantly having to inject their blood sugar, they're constantly having to inject insulin. And so most often what they'll end up being started on is a basal bolus regimen, right? They're going to be self-monitoring their blood glucose along with this. And when I say basal bolus, what does that mean? They'll have a long-acting providing the basal insulin activity throughout the day, and they'll be on a bolus around what time? Usually mealtime, and any other times you can think of? Usually nighttime, right? Because usually we'll check for nighttime hyperglycemia right before they go to bed, and then we'll give them an extra dose that they need to. We'll talk about some different ways we can do that. But again, that requires multiple daily injections. And who likes giving themselves injections? Probably nobody, right? Unless you have maybe some masochistic sort of patients out there. But most of the time, they don't like to inject themselves. And so we would like to give them as few injections as possible. So in some cases, you may try to mix different medications together. Sometimes you can't do that. It just depends on the situation and the type of drugs we're dealing with. However, one way we could get around that is maybe by giving continuous subcutaneous insulin pump. Right, I showed you guys a picture of the first insulin pumps that are out there. Yeah, not great. The new ones, though, I mean, they're super small, like the size of a lighter or something. Can be very good because again it's providing continuous insulin throughout the day, and then you can program in your boluses, right, based on the mealtime carbohydrates you're taking in, based on point of care checks on your glucose, things like that. Yes,
ma'am. Maybe I don't know if you'll know it, or like maybe you might know. When would you suggest somebody using one of those?
Mm-hmm. Good question. So when do you think using a sub-Q pump might be a good option?
Patient with arthritis can inject every time.
That could be one thing, right? So maybe they don't have the dexterity really to administer the medication. It could be one option.
Maybe like an irresponsible teenager.
Irresponsible teenager.
Yeah.
That's what irresponsible.
I mean, that's kind of redundant. A teenager.
A teenager?
Yeah.
Okay. Anyone else?
Needles.
Yeah, people don't like needles, maybe needle phobia, they don't want to keep injecting themselves. The thing you'll find with the sub-Q pumps is like patients really need to be with it as far as being in control of their diabetes, right? So you're going to find this is not for someone who is non-compliant. This is not for someone who is not going to think about checking their sugars. This is not for that, right? So this is for patients who are very well dialed in on their insulin regimen, and they would like to switch over to something that's a little bit more convenient, something where they don't have to inject themselves all the time, right? So again, this is not for the faint of heart. People really need to know what's going on with their diabetes and their disease state in order to understand how to manage it effectively. Now, again, you mentioned teenagers, and I see 9-year-old kids who are on this that know their diabetes in and out better than I would ever know it, right? And so the kid, or go ahead.
I was under the impression that it kind of did it for you. That's why I was thinking it was for irresponsible.
You would think that, but again, imagine if you have a patient who maybe they forget to eat lunch.
Yeah.
They skip lunch, right? And they don't program it into the pump that they're skipping lunch, right? Or they're going to go exercise, or they're going to do something strenuous, they don't program that into the pump. These are things that they get themselves into trouble. Either they get very hyperglycemic, or maybe they forget to program in a dose because they had a snack or something, right? These are things you have to be really careful with, and so they need to be really, really responsible from that standpoint. Yeah, so if it was like a rebellious teenager, be like, screw you, mom, I'm not going to manage my diabetes. Like, that's not good, because again, then you have this basal amount of insulin going into the patient, then get hypoglycemic and die, right? Yeah. So you have to be careful with that. But for instance, like whenever we use patient's own pumps over at Nemours, one of our responsibilities is to go and like check the pump out, make sure it looks good, and we check for competence with the patients, make sure that they know what they're doing, how do they actually use the thing, how do they program all this stuff in, and so, but like I said, I'll have like 7, 8, 9-year-olds who know this stuff in and out. They're like, oh yeah, when I get my meal, I know how many carbohydrates I'm getting in. I program this in based off of that. Their insulin sensitivity index is already programmed into the pump, so that way they just put in how many carbs they're having, and they'll get a basal dose of insulin to go along with that. So they're awesome. Like these little guys, they've been saddled with this huge burden, but they take it in stride. They're awesome for that stuff.
And you have to move the pump into different areas too?
Yeah, so you do have to change the catheter out. I'm not sure how frequently it needs to be moved from area to area, or side to side potentially. That would be a good question. And again, this is where your diabetic educators are like really helpful because they deal with these patients day in and day out. So they can maybe give you a little bit more information on that. Yeah, but you get to think about things like going to the shower, the catheters. Usually protected, so you should be able to shower along with that. They just kind of disconnect the pump and then put it back on. I think about things like infection. They gotta keep the site clean because that's going to be sitting there 24/7 for them. So little things to consider there. But and again, do the pumps always work? Do they sometimes malfunction? Just like everything, they can malfunction, either giving too much, too little, and so sometimes that's why our kids will end up in the hospital there, right? Yeah, so just depends on the patient. Depends on frequently you want someone who's got their disease state really dialed in before you start them on a sub-Q pump.
Does malfunction? Is there a way for you to reset it? How does that work?
You will either if it's the actual pump itself, like you can if it's something you can reset potentially, that could be something you'll do, but oftentimes you either have to get a new pump. So the companies are usually pretty good about being able to replace those if you have an issue there. It could be an issue where maybe the catheter came out or something. So it could be multiple different factors that go into that. But usually they either get profoundly hyper or hypoglycemic, and then you're managing them in the hospital from that standpoint, right? So it could be, yeah, we'll get you back on the pump eventually, but we got to get all this other stuff figured out in the meantime. So anyway, so looking at insulin administration, you can do less frequently. But what do you think are some of the downsides with that? Well, it's less injections, right? So again, people typically like that. What do you think is the downside of using fewer injections? Yeah, you're more likely to see hyperglycemia. So you don't have as tight a control on the blood sugar, right? If I use more injections, the positive side is that I'm going to get better tight control of that glucose. What is the downside of giving more injections? You're right, you're more likely to see hypoglycemia, right? So again, it's a balancing act between these two here. You want to look at the patient quality of life, you want to look at the risk for hypoglycemia, and you want to look at all these different factors here. So typically you need to make sure you're matching insulin intake on the carbohydrates they're ingesting and also on their physical activity. So if you had to imagine, what do you think, say, strenuous physical activity does to your insulin requirements? Goes up or goes down? Actually decreases it, right? Because again, you're going to find that because your body's being active, you're having that sympathetic nervous system kicking in, like you're going to use that blood sugar, right? So again, what we'll find is that if you're, say, for instance, going to go work out or something, patients will maybe decrease their dose of insulin or maybe skip it altogether potentially, depending on the situation. So that's something to consider, because if they use the same dose and all of a sudden they're starting to work out and all of a sudden the blood sugar starts to drop, the brain's going to take a hit, right? So then you're running a marathon, all of a sudden you pass out. Something to consider. And so typically what we're doing here is we want to try to mimic the effects of the pancreas as best we can using that basal bolus or regimen there. And so by using our different types of insulin, you're going to be able to try to mimic that as best you can, right? So that's why you need a combination of short-acting and long-acting insulins together. And anytime I see like a new diabetic coming through the pharmacy, I always see like a million different prescriptions because they got to get all these different meds on board, usually 2 different types of insulin, their glucagon, their testing strips, their needles, their glucometer, all the different stuff, how all has to go in together, because again, it's a big deal when someone gets one of these new diagnoses here. So, and again, twice daily administration is generally not going to be good enough because you're not going to be able to cover what time frame? Mealtime. Yeah, exactly. You're not going to cover mealtime and snacks and all that sort of stuff. So you'd like to do twice daily, that'd be great, but not going to be really good for your type 1 diabetic patients. Okay. So, as I mentioned, it's going to be either based off of them getting a long-acting insulin in the morning and the evening time. Sometimes you'll see a Q12, sometimes you'll see a Q24-hour, depends on which ones you're using. So for instance, like an insulin glargine or a Detamir or a Degludec, those are all the really long-acting ones. Those are typically one-time daily dosing, right? Versus like your MPH, your Ultralente, those might be more Q12-hour dosing. Honestly, How often I see the NPH insulins being used? Not very frequently. Most of the time, it's either going to be Levemir or Levemir, Lantus, or that Tresiba, right? One of those three are going to typically be your long-acting formulation, most often. And then using the regular to ultra short-acting insulins. And again, which one do you think we see more often, regular or the ultra? Usually the ultra short-acting ones, right? So most patients will either be on like a Pedra, which is the insulin glulicine, they'll be on the Humalog or the Novolog, one of those three. Most often Novolog or Humalog. And so again, the benefits there is they can take them closer to mealtime, so maybe 15 minutes as opposed to maybe 30 minutes or 45 minutes with regular insulin. And again, the onset is very quick and the offset is very quick as well, right? And so you can either use what we call a sliding scale. And so a sliding scale is going to be basically where you will check the blood sugar, see where it's at, and then based off of that, you're going to administer a certain dose of insulin, right? So typically you'll see these orders in the hospital, and if you get a chance on your rotations, you'll see these on there where they'll say, okay, if the blood sugar is, say, 80 to 100, don't do anything. If it's 100 to 200, you're going to get this many units. If it's 200 to 300, you did this many units. And so it's based on a sliding scale. So you'll check the sugar, see what it is, and you'll administer insulin doses based off of that, okay? Problem with that is it's usually going to be more reactive. So if they're already hyperglycemic, then you have to treat that, right? Versus if I could try to prevent the hyperglycemia, that's always preferable. Other things to consider there as well is that what is the patient's own insulin sensitivity, right? Type 1s we mentioned are going to be much more sensitive, meaning with 1 unit of insulin, you get a bigger change in blood glucose versus someone who's a type 2 diabetic patient gets a much smaller change with just 1 unit, okay? To keep that in mind as well. And so you'll often find that that will be calculated into your regimens when you see the sliding scales.
Is that because of the insulin resistance of type 2?
100%, yeah, absolutely right. So again, it takes more insulin to get the same change, so they'll be less sensitive to it. So you'll find that 1 unit itself may not make a whole hill of being a difference. Right? Yeah. And so then the other thing they will also do is very frequently they'll do carbohydrate counting, and this is really good because it's more proactive, right? You're doing it before you actually have the meal intake and deciding how much insulin they're going to receive, right? So for instance, they're eating a salad, probably don't need a ton of insulin, right? Versus they're having a fried donut from the fair, they probably need a whole heck of a lot of insulin, right? So it all depends on actually how many carbohydrates they're intaking. This is where like a lot of like fitness apps and things have been really helpful because you just go like MyFitnessPal and just program in, hey, I'm having a Twinkie. Okay, I need 20 units of insulin based off of that, right? Or if I'm having, kale salad, okay, I might need only 1 or 2. So again, it all goes back into the carbohydrates they're intaking, and you're giving an insulin dose that's commensurate with that carbohydrate intake, okay? Very, very helpful with that one. And then usually they'll have 3 times daily with meals, and they'll have like a nighttime correction or something. It might be more like a sliding scale. Sometimes you'll see them use both, actually. Yeah. So for instance, you'll use like a carbohydrate counting around meal times, and then at nighttime before I go to bed, they'll have like a sliding scale order where they'll say, hey, if it's 200, go ahead and give them this many units of insulin before bed. So sometimes you see a combination of the two. Frequently in the hospital, especially with like maybe patients who are not normally diabetic but maybe are critically ill, who are becoming hyperglycemic because they're really stressed. Sometimes we'll see them on a sliding scale sort of regimen there, right? Because they're not on normal meal times and things like that. So you'll see different regimens depending on what your patient's situation is.
Is there one that has less hypoglycemia effect? Or
you would probably see, if a patient wasn't carb counting effectively, or if they didn't really know what their insulin sensitivity was, that really wasn't well dialed in. Maybe more with the carb counting, just because you're giving a dose of insulin prior to actually even getting the carbohydrates in. Versus with the sliding scale, if their sugar's 300, okay, I already know they're hyperglycemic. I'm less likely to see hypoglycemia there, right? And so again, unless you work in endocrine specifically, very frequently you're going to find that you may not be as in depth on this or know the patients as well. So again, who are you going to consult? You're going to consult endo, right? So oftentimes you're going to go in, you're going to look at previous endo notes, you're going to see what they were recommending. Of course, and if the patient's coming into the ICU, you're probably going to consult them anyway to come see your patient, and then you'll just reorder that, right? That can be leading to some problems, though, right? So you got to be really careful with that. So for instance, I had this is like 2 weeks ago, right? So I had a patient who was a DKA patient coming in. They were known diabetic, but they got sick. Sometimes you'll find they get like a virus or something, and it just kind of throws them for a loop. So they came in for DKA, go to the ICU, they're on an insulin drip. They get better, right? We're going to correct the glucose, and then we're transitioning them back over to their home insulin regimen, right? So I had I believe it was the nurse practitioner who was ordering, and they basically went through their home meds and said, okay, what am I going to reorder here? So they ordered their insulin pump, right? So they said, okay, they're going to be on a Humalog insulin pump. That's another point as well. What type of insulin do you want to use in those continuous pumps? You want something short-acting. Anytime you use a continuous infusion, short-acting meds is the key thing there because you can titrate it very quickly. But This patient was, so she wrote orders for their continuous insulin pump, and then they also had written an order for Lantus. And Lantus, as we saw, was a what? Long-acting medication. And so to my mind, I was like, wait a second, that doesn't make sense. They're on this continuous pump that is providing basal insulin. I don't need a long-acting insulin on top of that. And so I called them up and said, hey, what's going on with this? And and again, it's funny. I asked this question to students years past, and I said, well, what do you think about that regimen? And they're like, well, that's dumb. Okay, well, maybe it doesn't make sense, but you don't want to go with that tact, right? So again, when I call a person, I don't want to be like, hey, this is dumb. Why are you doing that, right? And remember, be tactful, right? When you're talking with other providers, because they may know something you don't, right? Depends on what's going on. So anyway, so I talked to her. I said, hey, what's going on? This doesn't really make a whole lot of sense to me. Can you maybe help me out in trying to understand why they're on this kind of regimen? And of course, I tried to lead them to that point. It doesn't make sense because they're on the continuous pump. They're also on this long acting. I don't really see that normally. What do you think about that? Right? I'm trying to leading them to where I'm at. And she's like, oh my gosh, I just reordered from the home meds. I didn't even realize that doesn't even make sense. Let me check with Endo. It was actually an old prescription that used to be on the long acting before they got transitioned to the pump. And so because it's still on the med rec, they just reordered it, and there you go, right? So you be really, really careful with that stuff, figuring out what their actual current regimen is, and making sure it makes sense based off of what you're ordering, right? So again, that's a medication error that we averted based off of knowing that, okay, here's how insulin should be used in a patient. Okay, make sense? Anyway, again, that's not just a way for me to pat myself on the back, but it's one of those things where you have to think through. If something doesn't make sense, what do you got to do? Ask a question, right? Because again, you don't want to just be like, okay, well, I don't want to look stupid by asking questions. I'm just going to go ahead and just keep going with it. That can lead to big problems, right? So again, always be able to ask questions if you're ever curious. So anyway, so what are some different insulin regimens that we could do to try to kind of manage these patients here? And so some different ways you can try doing this, and I'll kind of show you kind of the glycemic control you can get with using these regimens here. So again, looking at normal blood glucose, normally you're going to see there's a basal amount of blood glucose, right? So normally your basal is not 0, otherwise you'd be dead, right? So you're going to have some amount of glucose, and you're going to see these spikes happen here around mealtime, right? So good, you're going to see spikes, and then you should see insulin go up along with that, right? So this is the normal sort of what a patient without diabetes would look like, okay? So how can we mimic that by giving our insulins? Well, here's an example of a regimen where we use regular insulin along with NPH insulin. Okay, so this would actually be a twice daily injection regimen. Okay, so this NPH we said is an intermediate acting, should be about 12 hours or so duration, and you have regular insulin that is longer than the short acting, but not as long as one of the intermediates, right? So you can see here they'll get both of these together. They would just do one injection. This is one of those cases where you can actually mix them together. And you do one injection in the morning around breakfast time. And again, what do you think your biggest carbohydrate intake is in terms of meals? You think breakfast, right? So you think breakfast is the most important meal. You're breaking the fast. You're having your sugary cereal, your pancakes. Think about most of your favorite breakfast foods are probably carbs, right? So again, you normally think about most of the carbs coming in during the breakfast time. And of course, if you have a big like chocolate cake or something at dinner time, that can be thrown for a loop. But just in general, kind of go with me here. So they'll have one injection in the morning that will cover them for breakfast, and then you'll find around lunchtime you should be seeing a little bit more of a peak with the NPH. And then by the time they get to dinner time, they're probably getting hyperglycemic here. You'll redose them again around dinner time, and they're good to go. Right. So you're going to find that while hypoglycemia risk is not great here, you're going to find that the glycemic control is not super tight. Because again, what about you have a lunchtime and you decide to have nachos with your taco or something like that, right? So you're going to get a lot of carbohydrates all in. You're probably going to find that postprandial lunchtime glucose is probably going to be elevated, right? Because you didn't give a specific insulin dose to cover that. Okay. So how can we do this other ways, right? So for instance, what if I use like an ultralente or something like a insulin glargine or a dedamine or something like that? Well, that long-acting, again, it doesn't really have a peak effect, but it deals with that basal blood glucose throughout the day, and then I will have regular insulin on top of that will provide coverage for the meal times. I could either do a postprandial check, which again is more reactive, but if I can go ahead and do carb counting beforehand, I'll know how much to administer. That again gives me better tight control. Now again, this would probably be a case where you're using 3 to 4 injections. Again, not great from a compliance standpoint, from the fact that they probably don't want to inject themselves as much. But again, it is what it is, right? So again, at some point you guys say, well, you're going to have to do it. And then looking at something like an insulin pump, you'll see here this is great because it will exactly mimic what the pancreas is doing by providing basal insulin and then spiking up around the times where you'd expect around meal times. Okay, so you can get the tightest control here, but again, if something goes wrong with the pump or you skip a meal or something like that, that can be problematic. Okay, can that make sense? So that's the goal, right? And again, ideally in the future, this may not even be an issue. We might have artificial pancreases that are doing this, or we'll have, you can have your Bluetooth connected glucometer that's constantly checking you and communicating with your pump, and you can take care of all of that. But we're not quite there yet. We did be there one day. I actually had a student a couple years ago who actually had a constant monitor that was a sub-Q monitor. It kept on the back of their arm, and it would communicate with their phone, and they could actually monitor that. One of the downfalls of that, though, is that it was kind of slow to equilibrate, right, from the blood sugar centrally to the subcutaneous sugar at the tissue there. So they actually find that maybe like an hour or two, in fact, before they would see, if they check like a finger stick, they'd be hyperglycemic, but the sub-Q one would actually read normal. It takes some time for that to re-equilibrate. So again, these technologies, there's always going to be some downfalls to that. But I thought it was pretty cool. You can do Bluetooth monitoring of your glucose, right? It's pretty awesome. So anyway, so we'll get there one day. But again, these are the different ways that we could try, the different kind of paradigms of administering insulin to deal with that glucose. So yes, sir. I'm not sure, sir. Yeah. Yeah, so normally when you see normal insulin release from the pancreas, it kind of has this kind of bimodal sort of peak there. And so again, that's just trying to mimic what the pancreas would normally be doing. Maybe it kind of deals with any kind of residual extra glucose around. Yeah, it's just normally what the pancreas does.
In the lifetime of a diabetic, do they try all types of regimens before they finally stop?
What I see most frequent, and again, I'm not an endocrinologist, all right, so if you talk to them, they'll have a much more intelligent answer, I would say. But what I frequently see is that we'll normally start a patient off on a carb counting regimen where they're going to be doing long acting in the morning time, and they'll be on 3 times daily short acting insulin around meal times, and then usually like a pre-bed kind of correction, right? So that way they may be doing 4 to 5 injections, all the different Medicaid. The unfortunate thing with the long-acting forms is you can't mix those with anything else. They're what they are, and they're by themselves. So that's the most frequent thing I see, and if they get really tight in control, because again, when you're starting a patient off on these insulins, like you're starting them off on kind of a bog standard sort of like this is what everyone's going to get, and then based off how they respond, what their blood sugars are, then you can kind of dial in and be like, okay, well this patient's a little less sensitive or more sensitive, and that gets you a little bit better idea of what you're going to be doing there.
What do they mean by can mix? So can I give, let's say, long acting, can I give a short acting right after, or do I have to wait a certain time before?
Not being them together, yeah. Because again, the nice thing about the long acting is they don't really ever peak, right? So again, they're just going to provide nice long acting control. You really shouldn't see any issues of giving that, right before breakfast time. Use your long acting, use your short acting, eat your breakfast, and then go about your day, right? Shouldn't be any issues with that. Yep. Okay, so looking at, and again, I'm not going to ask you specific dosing of insulin on here, but I just want to illustrate some points here that I think are important. So for instance, looking at a type 1 diabetic patient, you're going to see their insulin requirements are say 0.5 to 0.6 units per kilo per day, right? Versus a type 2 diabetic patient, what do you notice? Much higher requirements, right? Even though they're probably still producing some of their own insulin, they are very resistant, right? Those cells that say, oh, we got too much insulin around here, too much blood sugar, we're going to maybe go on strike a little bit here. We're not going to be as responsive. So because of that, they have much higher requirements. That makes sense. Normally what you'll do when you're putting a patient on a basal bolus sort of regimen is you'll do 50% as the basal, as your long acting, and then you'll split up the other 50% around the meal times. Just to give you an example, if you had a 40 kilogram female who's a type 1 diabetic patient, you'll find that their total insulin dose should be, say, 0.5 times 40, right? Kilograms cancel out, so they should be on 20 units per day. What am I going to do there? So at that point, I'm going to take 50% of that, and that's going to be my basal. So say, for instance, I'm going to do twice daily Detamir. So I'll do 5 units in the morning, 5 units at night. So that's your 50% covered there. And then the rest of it is going to be spread around meal times, right? So maybe 20% at breakfast, so 4 units of insulin Lispro, which is that short-acting insulin, 3 units at lunch, and 3 units at dinner. Now, if they say, like, I don't really eat really big breakfasts, I may have, like, a piece of fruit or something like that. Maybe you only do, say, 2 units of insulin at breakfast, and then I have a really, really heavy lunch. Then you can switch it around, right? Again, all of it's going to be based on what their normal habits are. So this would be, so in those cases, you may have, like, say, a correction where you would say, do like a postprandial check, and then if it comes back up high, then you would give a certain number of units of insulin. More frequently, what you're going to find is that this is kind of like a standard, like here's what you're going to start everyone off at, and then based off of what you see their insulin sensitivity is, then you can start to incorporate something like the carb counting regimen, and then, like I said, usually before nighttime, they'll have more of the sliding scale where they'll say, if it's between 100 and 200, you do this many units, if it's 200 to 300, you do this many units, etc. Right? So again, it just depends on those cases there. Now, a type 2 diabetic patient, are we going to start them on a basal bolus regimen like this? Frequently not, right? Frequently, we're just going to give them something to help provide a little extra insulin activity. So very frequently they only start off on a long-acting formulation, right? We'll just kind of give them, say, a single dose of Detamir a day in order to kind of help what their body's still producing and help their other medications work a little bit better. Okay, that makes sense? So anyway, and again, obviously they're all snowflakes. Again, that's not a derogatory thing. It just means everyone's a little different, right? Everyone has a little bit different journey, different genetic makeup, different diet. So again, you got to be able to individualize these, and that's where your endocrine colleagues are going to be super, super useful in helping with this, because most of the time what a provider is going to do, they're just going to copy and paste what was in the endo note back into the chart, and then that's going to be it, right? So again, make sure it's up to date. Make sure you talk to them. Make sure that's going to be appropriate for your patients. Because, you know, I had cases too where the provider will go ahead and just copy and paste over what was in the endo note and it's from like 6 months ago, and they finally talk to the endo provider and like, no, that's old. We don't do that anymore. This is what we're doing now. So again, you got to be careful of that stuff. As I mentioned, insulin pumps can be very useful. Again, they require extreme attention to detail because, you know, unlike a pancreas, when the pancreas senses low blood glucose, what does it do? Shuts down insulin production and increases glucagon production, right, or release. Insulin pump's not going to do that for you, right? So again, if you get hypoglycemia, that thing is still just going to keep pumping away. It doesn't know any better, right? Now again, 10 years from now, I might be talking about, you know, the auto pancreas 5000 and how great it is, but we're not right there yet. Okay, and so those malfunctions too can be a big issues. And of course, I was one time I was talking to students, and I was like, oh yeah, I don't really think these things malfunction that often. I had one student was like, oh, no, mine totally broke, and I ended up in the hospital for like a week. And I was like, oh geez, like, so it does happen, right? So you have to be really careful with those. Okay, so getting back to your question, so again, I said you're alluding to, you're foreshadowing, how do we treat hypoglycemia? And again, the easiest thing to say is what? What do you give them? Give them some sugar, right? So again, you have to be aware of what the signs and symptoms of hypoglycemia are. We talked about those already. Yes, sir.
So insulin pump, you said we can only use rapid acting, but in the other slide it says basal and bolus.
So the rapid acting insulin is providing both the basal and the bolus, right? So because it is a continuous infusion as opposed to just say a one-time dose, it is able to provide both of those, right? Because again, your pancreas only produces one type of insulin, right? It's just it has both the basal and a bolus sort of function there, okay? But again, that short-acting nature is the key thing with that. You always need to use short-acting meds because you can titrate them much more easily than something very long-acting, okay? Anyway, so again, and especially in like type 2 diabetic patients with extensive neuropathies, they may not even be able to detect that they're hypoglycemic in the normal means, right? So you got to be careful with this. Now, what do we consider to be hypoglycemic? Less than 60, 65, somewhere around there, right? So again, you may find it differs a little bit. But again, also if the patient has a level of 72 and they're feeling kind of woozy, like they're still hypoglycemic for them, okay? So that's something to consider there. Now, normally, what do you do when you get hangry, right? You get irritable, but when you get around some food, what do? You say, I'm only going to have just a little bit of these Pringles. No, you go Cookie Monster, and you get all that food in, right? So people tend to overcorrect on these sort of things, right? It's just kind of human nature. It's what your body's kind of trained to do. And so they tend to overcorrect too much, and then they get hyperglycemic, right, which is not our goal. So most of frequently what we'll do is recommend the rule of 15. So that's basically where they're going to intake 15 grams of a simple carbohydrate. Now, again, when I say simple versus complex, what does that mean? That's to do with the actual the makeup of the actual sugar itself. Something very short and easy to break down is a simple carbohydrate. Something like, say, wheat bread, whole wheat bread or something like that is a more complex carbohydrate. You have to break it down first before it can be absorbed. So we want simple carbohydrates, things like glucose, things like lactose, things like that. So say 8 ounces of orange juice, right? Some milk, say 4 glucose tablets. Most of the time they'll carry those around with them as well. Those are going to be 15 grams of carbohydrates. You're going to wait 15 minutes and check their blood glucose. And then if it's less than 70, then you'll repeat, right? The goal is to kind of slowly bring them back up to normal without trying to overcorrect and getting them hyperglycemic, okay? Now, again, this assumes what? The patient is still awake and with it, right? Now, again, we said with severe hyperglycemia, how do they present? Seizure, coma, death, right? So again, this is more extreme circumstances. So giving them, trying to put 4 tablets of glucose in their mouth when they're actively seizing hypoglycemia doesn't make a whole lot of sense, right? So what are we going to do in these cases? Well, we have a couple different options, right? So one, we can give them IV dextrose, but we also have something we can do beforehand, and that's going to be glucagon. And most new diabetics are going to get a prescription for glucagon in case they get hypoglycemic. Just like you give an EpiPen to an anaphylactic patient, or patient with anaphylaxis to peanuts, like you're going to be giving them glucagon. Because again, you never know when they're going to get hypoglycemic. They could be on the best regimen in the world, they're carb counting, all this kind of stuff, but they get sick or something, get a cold, a virus, like that can definitely throw them for a loop, so you got to be careful with that. So anyway, so what is glucagon going to do? Well, it stimulates production of glucose from the liver, right? It's going to be able to stimulate that glycogenolysis. You're breaking down glycogen, and it'll then stimulate gluconeogenesis, okay? Now, again, for that to occur, it's contingent on your liver containing what? Glycogen. You need that glycogen. You need that storage molecule in order to produce new glucose. What if you had a patient who's been kind of chronically hypoglycemic, or maybe they're malnourished or something like that, and they don't have glycogen stores? This drug's not going to be that effective, right? So again, this won't work for everyone, but it can work in most patients if they develop some hypoglycemia where oral intake is not going to be effective for them or appropriate for them. So basically what this does is, you see this kit right here. Now normally glucagon, again, it's an injectable product because it is a protein. It will come as a freeze-dried powder, right? So it helps with the stability there. And you'll find that the actual syringe will have the diluent. Let's say diluent, what is that? So we use to reconstitute the powder into the liquid form, right? So again, we freeze dry the powder so it stays stable. We'll have the diluent along with it to reconstitute that, okay? So basically they'll inject it into this little vial. They'll then allow it to reconstitute. So again, swirling, rolling, no shaking, right? And then once it's in the solution, they'll draw it back out, the syringe, and then they can inject it intramuscularly, okay? That's how they're going to be administering this. So it should allow for increases in blood glucose based off of that glucose coming from the liver there, right? Works pretty well. Actually, in some cases too, and one of the big side effects you're going to find with glucagon is actually nausea, vomiting. This is a very potent emetic sort of drug there, and a lot of it has to do with the fact that it loosens up some of the smooth muscle, especially in the esophagus. And it's actually interesting, sort of a side case where we'll use glucagon occasionally. And again, if you think about, like, say for instance, a kid comes in and mom's like, he swallowed a quarter. Is that a problem? Depends, right? So say for, if it gets past the esophagus and is in the stomach, you don't worry about it, right? It just goes right through. No big deal, right? If it comes out as 2 dimes and a nickel, then you got a problem, right? However, let's say you get that x-ray and you still find it stuck in the esophagus. That's where it becomes a problem, right? That's where it can cause damage there. You can potentially see perforations. You want to get that passed, right? And so if you say, for instance, like 11 o'clock on a Saturday night, you call up your GI, whoever's on call for GI, and they're like, hey, can you come in and scope this kid to get this quarter out? And they're like, I don't really want to come in. Give them some glucagon. It's very frequent they'll try to do so that way they don't have to come in. They'll give them glucagon, try to loosen up that esophageal muscle and allow it to pass. If it doesn't pass, which I will tell you frequently it does not, then you have to have the GI person come in, they'll scope them and get it out, right? So again, this is one of the things you may see that being used for someone who's not hypoglycemic, right? But because we know it's going to cause them to throw up, what do we give along with it? Give them some Zofran, right? It's going to be very helpful with that. Anyway, and then the other thing would be the IV dextrose, right? So again, if glucagon's not working or has been ineffective, and again, if you have a patient coming in, say via EMS, for hypoglycemia, what do you want to ask the paramedics and the EMTs? What have you already given them, right? What have you already done? Because very frequently, you have already received glucagon. There's no point giving another dose if they've already gotten it, right? It didn't work. So anyway, next we can do the IV dextrose. You'll find there's several different concentrations we have available. There's D10, D25, and D50. All has to do with the concentration of the dextrose. Obviously, D10 being the most dilute versus D50 being the most concentrated. Okay. Now again, could we just give D50 to everyone? No. Why is that? Do you guys know? Well, you're adjusting the dose, right? So again, I can give less of D50 to get the same effect as more D10, right? So again, I can change my dose, the volume I'm administering. Yeah, so it's very hyperosmolar and it's very hard on the veins. So again, especially if you think about like small kids, those little small friable veins, like they can be very, very well irritated. So we don't want to do that. So very frequently for small children or infants, we'll use D10 because it's easier on the veins. And then for adult patients, so I have someone who's like an adult patient who is comatose, maybe just had a seizure, like I'm giving them D50, right? You can just slam the whole vial of that, and that's good to go. You'll find that usually in code carts. You'll find D10, or you usually find a D25 for kids, and then you'll find like a D50 for adults.
We gotta wait for D10 because they found that basically patients were more likely to re-enter the hypoglycemic state faster with D50 versus D10.
Right, and that makes sense because if you think about it, if you give them a really huge bolus of dextrose, all of a sudden, what does the pancreas want to do? It stimulates insulin release, right? So again, you can sometimes find you have this kind of seesaw sort of pattern, right? So sometimes by giving, say, D10 a little bit slower, you'll kind of have a more gradual rise in blood sugar. You may not see that same increase there. I run into the same problem when I have patients with we'll talk about sulfonylureas in a little bit here for type 2 diabetics, but I'll have a patient overdoses on a sulfonylurea, which stimulates the pancreas to produce its own insulin. And so we'll give them a big bolus of glucose. Glucose will come up, but then it goes right back down because of insulin, and the pancreas says, well, let's release more, right? So a very good point there. Usually though, D10, D25 for small kids, D50 if you need to for an adult patient, right? And again, this is for people who are unconscious or are not able to take PO. Those are going to be the cases where you're going to use that, okay? And again, the gram, just a good thing to know, I'm not going to ask it on the test specifically, but 0.5 to 1 gram per kilo is generally pretty good, right? So by giving, if you look at crash carts, and I recommend you do this whenever you go on rotations, look at the crash carts to see what's in them. You'll find that the D50 usually comes like in a big 50 ml vial, and that's basically 25 grams of glucose. So you just know that, okay, I'm giving 25 grams of glucose. We'll see how they do, how they respond, and then go from there. Okay. Listen, I need you guys to keep me on track. I'm only 14 slides in. I've been talking for an hour already. This is too slow, right? Keep on track. Anyway, no, I'd like to focus on insulin so much because it is like, it's so important. You're going to see so many patients on it. And there's so many kind of, it's such a dangerous drug, but so effective. There's a lot to it, right? So that's why I like to focus on that. But moving more into the type 2 diabetic patients, right? So this will be a little bit more fast paced. I think you guys like that. But anyway, looking at the different organizations, you're going to find they have different recommendations for where patients should be at in terms of glucose. They're generally pretty similar though. So for instance, they're looking at the A1C being less than 7 or maybe less than 6.5, right? A1C is just what? It's the average sugar over the past 3 months, right? So again, everyone should know that, right? So again, you're monitoring that. You're looking to see kind of what their average is. You also want to look at things like their preprandial, their postprandial to kind of see how they're doing, right? So again, and what does the postprandial glucose really tell you? How much insulin they're releasing, how well they're responding to that insulin that they are producing themselves, right? So it kind of gives you a good idea. You're kind of challenging the system to see, like, okay, well, how much of this extra blood sugar is left around that should be in those cells there, right? And so how can we help with that? Okay. And again, we're moving more to type 2 diabetes now. So now we're talking about patients who produce insulin but are going to be insulin resistant, right? So that's the main thing we're focusing on. So typically with a type 2 diabetic patient, you get the diagnosis. Now again, looking at pancreatic function, do you think it's just like a light switch one day where it's just like, oh, now you're diabetic? No, this is a gradual process, right? These are a lot of patients who maybe don't go to the doctor very frequently. I read something the other day. It says like the true mark of being an adult is when you start scheduling your own doctor's appointments. I was like, oh gosh, I should probably schedule one, right? But so again, there's usually a gradual decline. Usually, depending on when they actually get checked, like, they may be pretty well progressed in terms of their insulin resistance and how well the pancreas is going to be producing insulin. So you get the diagnosis. Obviously, lifestyle modifications are the #1 thing you got to recommend. So diet, exercise, etc. Right? How often are these completely successful? Not very, right? So again, you're going to find a lot of people are very resistant to these. You're going to find patients. This is tough, right? These are the tough things you got to do. So hey, you can't eat this food anymore, right? Or if you do, it's a sometimes treat. It's not an all-time treat, right? It's you got to exercise, etc. So most patients end up on monotherapy at least, right? So we'll talk about drugs that are going to be good as monotherapy for helping to make better use of the insulin the patient's already using, right? We'll talk about insulin sensitizers. Right? These are going to be things that help the body use insulin better, either from helping the glucose not to produce, helping the liver not produce as much glucose, or helping the body, the cells, actually take in more glucose. Okay, those are going to be insulin sensitizers. Now, would an insulin sensitizer ever be effective in a type 1 patient? Probably not, right? Because their main issue is not a issue of insulin resistance, but lack of insulin production, right? Yes, ma'am.
Now, is it ever possible for a type 1 diabetic to later on in life also become type 2?
So the question is, can you have a type 1 diabetic who becomes insulin resistant? Yes, right. So they have really poor dietary control. Again, it's not as common, but it's one of those things where you could see some degree of insulin resistance. You may find their dose will go up over time, right?
Okay.
But you wouldn't, I don't know if you'd ever necessarily classify them as a type 2 diabetic once they have that type 1 diagnosis.
So you wouldn't give them like metformin later on?
So in those cases, you may find some utilization, right? Because again, it will help them to make use of the insulin you're injecting, make it a little bit more effective, right? So we'll talk about that in just a little bit. But then typically you're going to move more to combination oral therapy. So you use more than one medication. A lot of these come in combination products because we do know that you get better synergy here by combining them. And then finally, some of these patients will end up on needing both oral therapy and insulin, okay? It's usually not just insulin by itself because, again, we're going to see there's some drawbacks to that. We mentioned what's the big side effect of insulin. Hypoglycemia was the other big thing in the long term. Weight gain, right? And again, a lot of these patients tend to be overweight or obese. Okay. So anyway, if you were to look at, say, for instance, plasma glucose and insulin levels with patients, say, with just normal glucose tolerance, versus impaired glucose tolerance, right? So in that kind of pre-diabetic sort of stage, and then a type 2 diabetic patient, right? So what do you notice about the glucose? Okay, well, obviously the type 2 diabetic patient has the highest glucose levels. Okay, makes sense. But more interestingly, I think, is the insulin levels. What do you notice here about, say, for instance, someone with normal glucose tolerance? Well, you have a bolus of glucose come in via meal, and it'll spike up, and then it goes back down, right? Okay, that's good. For someone who's impaired glucose tolerance, what do you notice? Well, it spikes up, but it stays up for longer, right? Because you need more insulin. It's having a harder time shuttling that glucose into the cells there, so it's having to work harder. You're overworking the pancreas already, right? And then for a type 2 diabetic patient, what do you notice? Overall, they can't produce as much insulin, right? So as they get more progressive, you're going to find you eventually wear out the pancreas where they are not producing as much insulin, and that insulin is not working very well, okay? So you're going to see that these levels will stay up higher for longer, but they can't, get the same dose out of the pancreas as someone with maybe just impaired glucose tolerance, okay? So these are some things you're going to find. We'll talk about some other hormones that also have some changes when you get into someone with really more profound insulin resistance. And again, looking at insulin levels for someone, again, the green line is normal glucose tolerance. The orange line here is going to be type 2 diabetics. Notice here insulin levels are going to be spiking up for a normal glucose tolerance patient versus they don't get that same spike there, right? But the other interesting thing is the glucagon, okay? Normally, if you ingest a big, let's say a big sweet donut right now, what is your glucagon levels going to do? It should drop, right? Because again, you have a high blood sugar, so it says, well, I don't need any glucagon around because I have enough blood sugar here, right? So in a normal glucose tolerant patient, when you have intake of carbohydrates, you're going to find glucagon levels should decrease. Okay. Well, what happens in a type 2 diabetic patient? Well, they don't get the same signal, right? So you end up finding their glucagon levels stay higher for longer. What does that do to blood sugar? Increases, right? So there's already multiple factors here that are helping these patients to stay hyperglycemic. It's not just an insulin issue, it's a glucagon issue. We're going to find another hormone a little bit later. There's one called glucagon-like peptide, or incretin, that's going to have similar issues here as well for these patients, right? So anyway, so the major classes of drugs we're going to talk about here are going to be ones that stimulate the pancreas to make more insulin. It's going to include your sulfonylureas and your glutamides. We'll talk about drugs that sensitize the body to the insulin that you're already producing. It includes metformin and the TZDs, or the thiazolidinediones. You don't have to say that, just say TZDs, right? We'll have drugs that help to block the absorption of carbohydrates. This is going to be alpha glucosidase inhibitors. We'll have drugs that suppress glucagon. They'll decrease gastric emptying, and they'll decrease food intake. We'll talk about why that is in a little bit. And those are going to be your incretin mimetics, right? Or glucagon-like peptide mimetics. And then finally, we'll have one that just helps you to pee out the extra sugar. And those are going to be SGLT2 inhibitors. Okay, so those are the main classes we're going to talk about here. Okay, the newest group is probably the incretin mimetics and the SGLT2 inhibitors. Okay. So just to give you an idea of how the efficacy of some of these different drugs are, you're going to find that whether you're using a sulfonylurea or biguanide like metformin, you're going to find pretty good effects here, right? So you're going to get drops in your fasting plasma glucose, and you're also going to find good reductions in your A1C, which is great. You're going to find that by combining these meds together, you're going to get better synergy. But you have to think about what makes sense when you're combining these, right? So again, if I can use something that increases insulin production and use something else that helps that insulin to work better, you're going to see better synergy there, right? So think about kind of rational sense for mixing and matching these medications. So looking at the sulfonylureas, these are, again, oral hypoglycemics. So again, instead of putting a patient on exogenous insulin, subcutaneous insulin, we can put them on something that helps to stimulate insulin production within the own pancreas itself. Okay, we don't use a lot of the first generations anymore here, but the second generation ones tend to be much more potent. You have lower doses here, and this includes things like your glimepiride, your glyburide, and your glipizide. Right. Notice here a lot of these come as extended release preparations, so they actually will be able to have good long-lasting effects throughout the day without having multiple doses needed. Right, it's kind of a benefit. Glucotrol XL is kind of interesting. If you ever, this is a good education point actually. If you put a patient on Glucotrol XL, they may come back and say, "Oh my gosh, I don't think the drug is working." And you're like, "Well, how come?" They're like, "Well, because I saw the tablet in my poop." And you're like, "Wait a second, why is the tablet coming out in the poop?" Well, it actually has to do with the dosage form. Why it's an XL formulation. Actually, when you look at the tablet, there's a tiny, tiny hole going through one side of it. And so what happens is once it gets into the GI tract via osmotic pressure from all the fluid in the GI tract, it'll actually force the drug out slowly over a 24-hour period. So the tablet never dissolves like a normal tablet. It's actually plastic. And when it comes out, you'll still find the tablet there in the feces. But the drug is gone. It's already been expelled out through that tiny hole, but it's will end up in the feces. So again, if you saw something like that, you'd be like, well, I don't think the drug is working. When actually it is. Anyway, we'll change it there. So how do these work? Basically, and if you go back to the slide where we talked about how insulin release is actually stimulated in the first place, what these are going to do is actually directly close those potassium channels, right? Remember, by closing potassium channels and decreasing efflux, what does that do to the cell? Is it more positive, more negative? There's more potassium in the cell, so it means it's going to be more positive, right? That's going to cause a depolarization. So then it's going to eventually cause those calcium channels that are voltage gated to open up, right? Because the positivity has gone up, so it's going to open up, and it's going to allow calcium to come in. And we know calcium stimulates vesicle release of insulin vesicles, right? So again, these are directly going to stimulate the potassium channels to close. Now, normally, what stimulates those to close in the first place? Normally, glucose coming in, glucose turning into ATP, and then that will normally close it, okay? You're going to find that normally in cases where you're hypoglycemic, right, or you have low blood sugar levels, you're going to find that normally that glucose never comes in and it never closes that, right? Well, what would happen if I had something that just came and closed these potassium channels anyway? Well, you're going to get more insulin release. Even if you are hypoglycemic, you're going to find it's still going to stimulate more insulin release. So again, these drugs, the biggest side effect you're going to see with this is what? Hypoglycemia, right? Because independent of what the blood sugar is, it's still going to stimulate insulin release, right? So you're going to find that you have to be really careful with these because, especially in older patients, maybe don't have a whole lot of, reserve in terms of physiologic function. You're going to find they tend to become more hypoglycemic. This is a very dangerous set of meds here. And again, when you have a patient who presents with altered mental status, you got to go through a couple of different things. You got to look at their oxygen. You got to look at their glucose. You got to look at meds potentially causing this. This is one of the things you want to consider, right? So look at their history, see what meds they're on. Anyway, so by doing that, it's going to help to decrease insulin levels being released. It's going to help to decrease the hepatic production of glucose. It's going to help the cells to be more responsive to the insulin. So a lot of different things here, right? And these are all good things to help, again, make more insulin, should be working better. So you're going to find that depending on the patient, especially if they have liver disease, they might actually be holding on to more of these drugs for longer, which may increase the hypoglycemic effects. It's something to be considered of. And again, remember, how is insulin cleared from the body? Well, via the liver and the kidneys. Again, if you have poor kidney function, these patients will hold on to insulin for longer. They're going to get more hypoglycemic, right? So you have to be careful with that. I see that a lot, especially if I have patients like in the ICU who are like maybe have sepsis and you put them on an insulin drip to control their blood sugar. They can get hypoglycemic because their renal function goes down. They're not clearing as well, right? So something to consider there. And again, these are we'll talk about which ones are good for pregnant patients. This is not going to be it, right? Because you can actually deplete insulin levels in the fetal pancreas, and you don't want to do that, right? So just to give you an idea, things like chlorpropamide's a first-generation agent, but we didn't really like it in the elderly because, again, it's very long-acting. So if they were going to get hypoglycemic, it was going to be a long-lasting problem, right? So I had to keep taking glucose. And, again, this one actually had a disulfiram reaction to alcohol. Again, you guys remember that reaction? You get flushed and throw up and all that good stuff. So we don't like that, right? Finally, glyburide, again, is a common one. You see in the XL formulation. Again, those are the two that are most likely to cause hypoglycemia. So just be aware of that. So, and again, some other kind of side benefits of these drugs, you will get a little bit of insulin sensitivity back by using these medications there, so it's kind of a nice thing. But just know that if you were to ever use these drugs along with insulin, keep in mind you have to decrease the dose of insulin that's going to be required because of the fact that this is going to stimulate the pancreas to produce its own. Okay, more often than not, you're not going to see these in combination with insulin. More often, I will see other insulin sensitizers being used instead of one of these if you're having to use exogenous insulin. Okay. Again, as I mentioned, glyburide is more commonly cause hypoglycemia there, and then glipizide not as great from a kind of long-term sort of effect, but that's why I have an XL formulation because it will help with kind of more kind of 24-hour sort of coverage here. Okay, so as I mentioned, hypoglycemia is going to be a big side effect in the short term. The long term, you're going to see what happens to the weight gain. Just like you would see with if you start a patient on insulin, you're going to see weight go up in those cases there, so something to consider. Other than that, it's pretty well tolerated. You may find that the patient may develop resistance over time. What do you think that is? Because again, as pancreatic function goes down, eventually you're not going to be able to release as much insulin, right? You're just going to wear it out. So again, this is going to be stimulating that kind of wearing out process because it's directly causing more release.
Yeah. Wouldn't you maybe not want to use these just because it would make your those cells in the pancreas even worse because they're already becoming there's already hyperplasia occurring, there's already necrosis occurring, so it's gonna.
So you're going to find that this is not a good first stop, but this is a good kind of add-on medication, right? So again, this is something where if you got to get the glucose under control, and if a patient really doesn't want to go on insulin, this may be a good stop for them, right? Even though we know it may help to enhance that kind of the wearing out process, right? Maybe they're like, I'm not going to live that long anyway, so I don't have to worry about it, right? I don't know.
Is it kind of like levodopa, carbidopa? The way
A little bit, yeah. How levodopa could kind of enhance
Yeah.
the destruction of the dopaminergic neurons. Yeah, absolutely. Kind of a similar process there. Now again, is there like a ton of literature saying like if you use this, patients are going to move on to insulin that much more quickly? I don't think there's any evidence to show that specifically, but it's something, at least a theoretical thing you'd consider. Okay. Anyway, so again, contraindications, obviously they have DKA, you're not going to be using this in order to manage that. Exogenous insulin is going to be the main treatment for that. A type 1 diabetic patient, would they get much benefit from a sulfonylurea? Nope, because they can't produce any insulin themselves, right? That's already their main problem there. And again, pregnancy would not be recommended. Obviously, anything that's going to be increasing blood sugar, like, epinephrine, dobutamine, any drugs like that's going to decrease the effectiveness, and again, be aware of the disulfiram reactions. Okay. Now, the meglitinides are pretty similar to the sulfonylureas. The main difference here is that they only are going to work in the presence of high levels of blood sugar, right? So again, these are going to be things that are better around what time of day do you think? Mealtime, right? That's when you have the biggest intake of carbohydrates. And so you're going to find that overall these are less effective than the sulfonylureas. They're not used as frequently as the sulfonylureas, but they also produce less hypoglycemia because again, you're really going to work when you're taking in carbohydrates. So if you're not taking in carbohydrates, it's not going to work that well, and you're less likely to see hypoglycemia. And again, when I give you the big table at the end that kind of compares all the different drugs, hypoglycemia risk is one of the big things you have to look for, right? Because again, if I have a patient who's say 70 years old, they live at home by themselves, and I'm putting them on an agent that is highly likely to cause hypoglycemia, is that a good thing? No, because if they pass out because of hypoglycemia, no one's there to watch them. I'm dead, right?
So you said it only works when the glucose concentration is above a certain.
Well, like around when you have carbohydrate intake happening, right? So again, it's not necessarily a certain threshold of blood sugar, but it just works better when the blood sugar is high, right? And essentially what we're getting at there. And again, the mechanism is the same. It's just going to be much more dependent on having high blood sugar levels, right? So again, as far as things to consider here, you need to take them before meals. That makes sense because again, you want them to be working in response to that increase in blood sugar around that time. And again, might have to be given more frequently. May be bad from a compliance sort of standpoint there. Okay. Now again, these are also useful if you combine them with other medications like metformin. You're going to talk about rational combinations here in a little bit. But again, these can be useful if used in conjunction with other things. And obviously, if you miss a meal, you should probably skip a dose of this because again, it's not going to be all that effective. Same side effects, but you're typically going to find these are less likely to occur than with the sulfonylureas. Weight gain is probably not going to be as severe, probably not going to see as much hypoglycemia risk as you would with the sulfonylurea, like Livizide. Okay, getting into the biguanide. Oh, yes, sir. The what? Not necessarily, because it's more of a chronic issue, due to osteoarthritis. But this is more, you can just see some joint pain associated with the med. Yeah, it's been reported. Up next is the biguanides. These are going to be insulin sensitizers, and frequently this is the first set of drugs you're going to be putting a patient on when they get a diagnosis of type 2 diabetes. There's some other cases you might use it as well. You guys covered PCOS at all yet? When you cover that, you'll find that metformin is sometimes used in cases of that. We won't get into that here necessarily, but there's some other cases where you might find a patient who is non-diabetic being put on metformin potentially. But you'll find this very frequently in combination with other agents. So typically metformin plus glyburide, right? Metformin plus rosiglitazone, right? Different combinations because you will see synergy between these meds here. So what do the biguanides do? What does metformin do? Basically, what it's going to do is help to decrease hepatic production of glucose. Right, so it's automatically going to have an effect on driving blood sugar. You're going to find it's going to help with peripheral glucose uptake and utilization. That's the insulin sensitizing effect. So again, it's going to help the insulin you're already producing work a little better, and it will help to decrease glucose absorption from the GI tract. So what that means is, from a side effect profile, is very limited risk of hypoglycemia, very little weight gain. If anything, you'll find it's either weight neutral or some patients may actually lose a little bit of weight, based off the fact you're not intaking as much carbohydrates from the GI tract. Okay, so again, this is why we like this drug as a first-line agent, because it works pretty well, less likely to cause hypoglycemia, and really no big effects on the weight. If anything, if you lose a couple pounds, that's going to be beneficial for them, right? So looking at the kinetics here, it's important to know that while metformin does not metabolize in the liver, it's really important that you have good liver function with this. And the reason why that is that what you can actually find is that metformin stimulates production of lactic acid. So if I were to say give this to someone, to a patient who maybe can't process that lactic acid in the liver, you can develop a lactic acidosis, right? So again, if this is going to kill somebody, this is what's going to happen. Why it's going to occur is this lactic acidosis. I've seen a few fatal cases of this happen in the past. But basically, it gets excreted unchanged from the kidneys, and so you have to really watch for renal function. So if this is not being cleared through the kidneys, and they start to build up levels of that, lactic acid is going to build up, and that's where you can see the lactic acidosis develop there, okay? Especially if you consider patients who may have more dynamic renal function. So say, for instance, I have a patient who goes into the ICU for sepsis. We know renal function can take a hit when you have things like hyperperfusion of the kidneys, right? That could be a case where you want to stop their metformin because you know renal function may go down.
Why is it contraindicated in hepatic disease if it's not metabolized in liver?
Because of the lactic acid issue, right? Because you can't metabolize the lactic acid as well. So you can so you may have someone who's maybe can handle it okay at normal dosing, but say, for instance, maybe they get dehydrated, they take a hit in their renal function, levels build up, and all of a sudden they get that. And I've seen that frequently where patients will have elderly patients who may be living in a nursing home, they're on metformin, and all of a sudden they get sick or they get dehydrated. No one's really watching them that close. All of a sudden renal function takes a hit, levels of metformin build up, and then their liver just can't keep up with that lactic acid. Yeah, see a couple of cases of that. So anyway, but again, for most patients, this is a really good drug. The biggest side effects you're going to run into are going to be the adverse GI side effects. A lot of nausea, vomiting, diarrhea associated with this. So one thing you want to do is either using an XL formulation, where you can have just a one-time daily dose, but it is slowly released to the GI tract throughout the day, or using BID dosing, right? That can help with that as well. So again, it's frequently the biggest reason why people discontinue use of this is the GI side effects. Okay. So glucophage can be pretty tough on the stomach.
Don't they get over that?
Yeah, there's some tolerance you can develop with that, or if like some patients will do better if they eat it with food or without food. It just depends on what what works best for them. Yep. Anyway, so as I mentioned, the GI effects are the biggest thing. The lactic acidosis. You have to be really careful. If a patient has decrease in kidney function, they need to be taken off of their metformin. If they're going to be put into a situation where renal function may take a hit, they should be taken off the metformin. Because again, if I have a patient who's coming into the hospital, say for surgery, right? Because you could have cases where you have hyperperfusion of the kidneys, you can see a transient decrease in renal function. I can take them off their metformin. Sure, their glucose may go up, but how can I manage that in the hospital? I can give them insulin. I can give them a sliding scale insulin and take care of that, right? So I can manage insulin I can manage glucose very easily in the hospital setting. So on the outside of the hospital, it gets a little bit more difficult, right? Because again, we're controlling what they eat, we're controlling what meds they get, all that sort of thing. They're our captive audience, so to speak, right? Just kidding. You want them to be an active partner with you, but again, we kind of dictate what's going to be happening with them for a lot of that. But so for those patients there, you can take them off the metformin. That's okay, right? Versus if you had like a type 1 diabetic patient, you can't just take them off insulin, right? So it's kind of the differences with those. But anyway, other things you may find, you may have a decrease in B12 absorption, so you could see megaloblastic anemia. It's pretty rare, but it's something you may consider. So as I mentioned, if they have a GFR less than 30, do not have them on metformin, right? You need to take them off that. You need to watch them over time, though, because again, some patients will be on this drug for decades. You got to monitor that renal function over time. Okay, we used to do it based off of their actual serum creatinine, which is not recommended anymore. Now their GFR is less than 30, just get them off of it entirely. Okay, the hepatic disease, they have an acidosis, is not a good drug for them. Anything like that. So again, and as I mentioned, we'll oftentimes stop it before surgery. If you have a patient who needs to undergo a CT scan or something with iodated contrast, that's something we'd also probably want to go ahead and DC metformin a few days beforehand, because we do know things like contrast-induced nephropathy can occur, etc. Right? So anytime you suspect they may have a hit to the kidney function, just take them off the metformin for a few days beforehand. Right? Once kidney function returns, you can put them back on it. No problem. Okay. Moving on to the TZDs, or the thiazolidinediones. Again, if you can say that, you can impress your friends. But again, just say TZDs, it's fine. Now this is a group of drugs that is used less frequently nowadays, mainly because of some of the notoriety that came about from one of the medications here. But the two you'll see are going to be pioglitazone and rosiglitazone. Okay, and so basically what these are going to do is they work to agonize and activate this PPAR gamma protein, right? So it stands for peroxisome proliferator activator receptor gamma. It's called PPAR gamma, right? And basically what this does, it actually regulates gene transcription at the nuclear level, and will help with things like insulin responsive genes. It's going to help with things like lipid and glucose metabolism. So again, these are working as insulin sensitizers, but these are going to be working at the nuclear level, right? So it may take some time to kick in, but once they do, they tend to be pretty well effective there. Now, you'll see better peripheral glucose uptake and utilization, because insulin is going to be, the cells are more sensitive to the effects of insulin. You're also going to find less hepatic insulin production. great from that standpoint, right? So in general, it's going to be pretty similarly effective as metformin. Again, you're not going to see a lot of weight gain associated with this, which is also a nice benefit there, right? And again, but it takes time to kick in, just like we talked about steroids take time to kick in because they work at the nucleus. The same thing is happening here, okay? So the big problems you want to watch out for are going to be the cardiac effects here, and this is why a lot of these drugs don't get used much anymore. And in fact, if you ever get the unfortunate opportunity to watch daytime television, you see those lawyer commercials. They're like, "Were you taking Zofran? You had QT prolongation. We can get you money, right?" There was a lot of them for pioglitazone here as well, mainly due to the fact. Actually, I think it was rosiglitazone. I have a slide on that in a second. But basically, they're saying if you were on this drug and you had a heart attack, we can get you money for this, right? Because of some of the notoriety that came about, some of the studies we found that actually increased cardiac risk of death, okay? Anyway, but if you have a patient with CHF, these are not good drugs for them because it can actually cause expanded blood volume, can worsen edema, worsen heart failure, so you do want to avoid that in those patients there. Not sure why the AC is like kicking in high gear. I wonder if it'll even pick up on the recording. I'll assume it's not going to blow up on me at any point here, but anyway. You may have some negative effects on your lipid panels. You do want to watch for that. And again, you have to monitor for liver enzymes because this can be hepatotoxic. Again, make sure you're monitoring ALT, AST. Once it gets above 2 to 3 times normal, that's when you want to consider taking off the drug, right? That shows you you're spilling those enzymes into the blood, shows you something's not right happening with the liver. So rosiglitazone, that's why the way I remember that is that it's not so rosy of a drug, because it had some of the negative cardiovascular effects. And again, it was pretty close, right? It wasn't really a slam dunk like, yeah, this is killing people. But there was enough, when you pulled all the data together, it looked like there was an increased risk for cardiovascular death. So because of that, a lot of people they didn't take it off the market specifically, but they said, no, we're just not going to use this anymore, right? So you'll see TZDs not being used as frequently, but pioglitazone may still see being used with like metformin. That does make sense from a synergistic standpoint. Okay, the next group we have here are going to be our alpha glucosidase inhibitors. This includes acarbose and miglatol. Basically, what these do is they block absorption of glucose in the GI tract, right? By blocking the enzyme alpha glucosidase, you can't break down some of those sugars, so more of it stays in the GI tract, and where does it end up being excreted? Through the feces, right? Okay, so what happens if you have all the extra sugar sitting there in your GI tract? The bugs are going to eat it. The bugs turn into what? Into
well, I'm just thinking of the byproducts, so maybe
byproduct, right? So for I'm trying to take up a new hobby of home brewing, right? So I do a lot of brewing of wine and beer and things like that. And when you put yeast into this, basically you just get a big vat of sugar water, right? You get grape juice, essentially, if you're doing some wine. It turns it into alcohol, but the other byproduct is CO2, right? So I have to have a little bubbler on there to make sure I can vent all the gas out. So again, imagine all that gas being produced in your GI tract. What does that show up as? Bloated, abdominal distension, pain, flatulence, right? So again, from that standpoint, does it sound like a very good drug from patient quality of life? Not great, right? So especially if you have a big carbohydrate meal, right? So if you say, I'm going to go to Olive Garden, I'm going to shut that place down, you're going to have some problems, right? Because all that sugar is going to stay in the GI tract and it's going to turn into some serious gas, right? So from that standpoint, not a popular group of drugs. The benefit, though, is they don't really get absorbed systemically, so you don't really see a lot of systemic exposure, right? So what does that mean? Who could that be good for, potentially? What kind of patient do you not want to have a lot of systemic drug exposure? Pregnancy is a big one, right? So you say, oh, let's give this to pregnant patients. However, when you think of pregnant patients, they already have a host of GI problems anyway, right? So you're going to have hemorrhoids and they have vomiting, like, right? So again, this is not something I would want to give my pregnant wife if that was the case. But this is something you could use if they did not want to go on insulin, right? Maybe they had a contraindication, maybe they don't like needles. This could be something that could be used there, right? So again, you'll find this being used not too often, but occasionally it may come up, right?
Can you take like gas?
I don't think so, right? So this isn't really, because again, you're just talking about the volume of gases being produced with all these little bacteria chumping all that glucose and turning it into, eventually CO2, right? So again, it is what it is, right? So, but again, if you take maybe say a low carbohydrate meal, right, that can help to mitigate some of that, right? Which these patients should be probably doing anyway, right? So just things to consider. But typically you'll take it with meals, right? If you skip a meal, you probably skip a dose of this. But those are the big things that we're talking about here. And again, not used as a first line agent, but used in combination with other stuff because you're going to see some synergy there. Okay. As I mentioned, abdominal pain, flatulence, diarrhea, very, very common, mainly due to all those undigested carbohydrates, right? And who would you not want to use this in? Well, obviously anyone with any kind of inflammatory bowel disease, because this is just going to aggravate that even worse, right? If you're trying to expand all that really inflamed tissue, not going to be good for them. Anyone with any kind of obstruction, anything like that, not good for them either, okay? So this is where you get into like kind of the interesting newer medications here. This is what I'm, really kind of cool drugs. So we have the incretins, right? So basically, there's one big one we'll talk about called GLP-1, right? This is glucagon-like peptide. Now, just because it says glucagon-like peptide does not mean it does the same actions as glucagon. Okay, that's going to be a little counterintuitive. We're actually going to find the kind of opposite effects, if anything. So normally, what you're going to find is that incretin or glucagon-like peptide 1 gets stimulated in response to oral carbohydrate intake. Okay. Is demonstrated by this graph here, where you notice that if I were to give oral glucose or IV glucose, and you're looking at levels of, if you look at the glucose levels here, you're going to notice that these are identical between the two, right? So again, either given oral dose or an IV dose, you should see, identical increases in glucose here. But if you were to look at the actual level of incretin, this incretin effect here, you're going to notice it's much more pronounced when you have an oral glucose intake versus IV glucose. Okay, so again, and how are most of your patients getting their food? Orally, right? Most of them are not on TPN, on parenteral nutrition, so most of them are taking their food in orally, okay? So what does this incretin do, right? Well, it does a host of different things. So for instance, it's going to be stimulated in response to high blood sugar levels, right? So as glucose goes up, it's going to get stimulated to be released, okay? Actually, some of it is going to be coming from these intestinal cells. Some of it you're going to find gets released from the pancreas. But what it's going to do is, one, it's going to help to increase insulin release from the pancreas. That's a good thing, right? For these diabetic patients. It's going to decrease gastric emptying. It's going to decrease food intake. Why would gastric emptying have anything to do with food intake? You feel full, right? So again, if I feel my stomach is completely full because nothing's leaving it or slowed down, then that's going to be say, hey, I probably don't need to use much. Also helps to stimulate some of the satiety centers in the brain, right? So that way I say, okay, well, I don't feel hungry. I don't have, because again, a lot of times these patients, you just have that kind of absent-minded kind of eating, right? They get bored or they just eat stuff, right? But if your brain is kind of turned off where it says like, oh, I'm not really hungry, I'm not going to eat, you will end up seeing what happens to the weight. Weight is going to decrease. And in fact, some of these drugs are now starting to be used specifically for weight loss. So this is one of the big changes you're going to see with some of these drugs being used here. But we'll talk about that in a second. Anyway, so two ways we can do this. We can either give a drug that mimics the effect of GLP-1, because the patient, especially in type 2 diabetic patients, they're not producing enough of their own. Or we can try to help inhibit the breakdown of the GLP-1 that are actually producing themselves. And so there's an enzyme called dipeptidyl peptidase 4, or DPP4. We got PPAR gamma, we got DPP4, so there's a lot of acronyms here. But by inhibiting this enzyme, you can inhibit the breakdown of GLP-1 and make it stick around for longer. Okay, which one do you think is going to be more effective? Probably giving something that acts like GLP-1, just like by giving someone insulin, typically more effective than trying to help them use insulin better, right? So just like in those cases there, by giving the thing that's going to act like GLP-1, it's going to be much more effective than something that just helps to block the breakdown of it. Okay, so just something to keep in the back of your mind, because again, we'll have drugs that fit into both of these categories here. But here's a nice kind of picture kind of showing you the different effects here. So again, it's going to promote satiety, will reduce appetite. You're going to see less glucose secretion and less more insulin secretion, and less glucose going to be coming from the liver, right? So all these things are going to be very, very effective. However, if we're giving something that is looks just like glucagon-like peptide, which is a peptide, how do you think he's going to have to be given? Yeah, there's going to be another injectable product we're going to see with these, right? The DPP4 inhibitors will be oral. These are going to be injectable products, right? So if you're already talking about a patient who might be putting on insulin, right? So again, we're talking about more injections already, so something to think about. So, as I mentioned, with type 2 diabetic patients, you'll typically find they have diminished levels of insulin because they're kind of wearing out the pancreas. You'll also find they'll have decreased postprandial levels of GLP-1, and so by giving them a replacement, you're going to help to get those levels back into control, right? You're going to help them to suppress that glucagon secretion. You're going to help them release more insulin, kind of get them back to normal, so to speak. Okay. As I mentioned, you're going to find an increase in satiety, decrease in gastric emptying, also going to be really good for helping them to intake less carbohydrates in general.
Is it possible to get into symptoms like gastroparesis though?
Good question. We're going to find out in just a second. Great foreshadowing. Thank you so much. Yes, sir.
So, similar to
I've never seen glucagon given intranasally. That's interesting. Yeah. No, so again, these have opposite effects, right? So you're going to find that this actually suppresses glucagon. So even though it's a glucagon-like peptide, it has more. And again, whoever the scientist naming these products are or whatever, it is what it is. But these actually have kind of opposite effects. So this will suppress glucagon secretion, increase insulin secretion. So again, if anything, it should have a hypoglycemic effect, right? So anyway, and again, looking at this, again, a lot of this change in insulin secretion and glucagon secretion is due to the fact that they're not releasing as much GLP-1, right? So again, this is a relatively newer discovery we're figuring out, is that GLP-1 is probably one of the big problems with these patients, right? So, and again, looking at GLP-1 with a normal glucose tolerant patient versus a type 2 diabetic patient, you're going to see that they're going to just have a whole lot less that are being released here. So I can either try to help prevent the breakdown of what they are releasing, or I can just get something to try to get them back up to, say, normal levels. Okay. So why do I have a picture of a Gila monster here? This is where the first incretin mimetic we had actually came from. So again, whoever the scientist was that said, let's take some spit from a Gila monster, analyze that, and actually found that I have a protein there that has very close homology to our own GLP-1. Again, who knows what else is out there, right? Man, there's some deep sea creature that produces something that looks just like, I don't know, any kind of chemical, right? Anyway, but so thank goodness they did it though, because now we have a whole new class of drugs that work very well. And so basically what they found is that they were able to take this first drug here called exenatide or Byetta, and they found that it had very close homology with our own GLP-1. And by injecting this, you get very similar activities to what our own GLP-1 does. And so basically what we would do initially was we were giving this to type 2 diabetic patients who maybe are on metformin. They weren't really at the point where they needed insulin yet, but we were going to give them something else to try to get things under control. And this came into play, right? This is where this might be the first injectable product these type 2 patients end up going on. The other big thing is it caused weight loss. And again, if it causes weight loss, what's that going to do to their glycemic control in general? It's going to get better, right? Obviously, right? So again, if they're getting less carbohydrates coming in their diet, they're going to get better glycemic control just from that alone. Also, a big benefit here is you actually don't see a whole lot of hypoglycemia associated with this, right? Because it doesn't really do anything to necessarily, it doesn't stimulate as much insulin release as like a sulfonylurea does. So you may see some risk, but not nearly as much as you would something like insulin or a sulfonylurea would, right? So it's a benefit. So weight loss is a big one. You're going to find low risk of hypoglycemia. Works synergistically with metformin and other medications we're talking about here. And then, what do you think is the downside, though? Yeah, so injectable product is a big thing, and then it's cost, right? So again, these are going to be very expensive because again, these are new meds. They're proteins. They're going to be expensive. Okay. And the first time we had them, we actually had to give twice daily injections, right? So again, that was also a downside of exenatide as well, is that it was expensive, and you're having to give 2 injections a day. Not a great drug from that standpoint. So, but again, to show you how effective it was, basically looking at this insulin response, you can see here by looking at insulin levels in these patients here. So healthy controls, this is what you would expect to see in their glucose levels, right? If you were to compare that with a type 2 diabetic patient, the blue line here is going to be placebo effect, right? So again, they just got, just saline. And you're going to find here they really didn't see that same sort of spike in insulin like you would with a normal glucose tolerant patient, versus if I give them exenatide, what do you notice here? You have much closer spiking levels as you would with someone who has normal glucose tolerance. So again, you're helping to restore the normal order by giving them something that helps to replace what they're not secreting on their own. Okay. So you can find nausea, vomiting being a big side effect here because again of the decreased gastric emptying time. So again, it's kind of like stimulating that gastroparesis sort of effect. So you absolutely will see that. If you're combining this with something like a sulfonylurea, you may be more likely to see hypoglycemia. But again, the risk of by itself is not huge. You may see delay of absorption of other oral medications, right? It makes sense because you have decreased gastric emptying, right? You can see weight loss, which may be a double-edged sword. I'll tell you quickly a story about my uncle. If you guys are familiar with the term diabetes, you don't know where that comes from. It's from Wilford Brimley, right? That's probably the guy who kind of most popularized it. You guys ever see his commercials? They're like, you need your diabetic testing supplies. That's Wilford Brimley. He's an actor, right? He's the movie The Thing, Cocoon. He's in some older 80s sci-fi movies, right? So anyway, but he always said, my diabetes, blah blah blah, and so anyway, so that's kind of where he got his internet celebrity. But I have an uncle that looks just like that, right? And so sure enough, guess what he also has? Diabetes, right? So anyway, but he's always been like very overweight and just had really poorly controlled diabetes, and so he ended up getting put on one of these medications there, and I didn't probably see him for like a 6-month period or something like that, right? So maybe like from 4th of July to Christmas time or something like that. And when I saw him, the guy looked like a shadow of himself. I was just like, what happened? Like, the dude must have dropped like 70, 80 pounds. I'm just like, what happened? He's like, oh, I got put on this drug on the next slide is called Victoza. I was like, wow, that's amazing that it worked so effectively. It worked great, right? However, it's a double-edged sword, right? So again, he just didn't feel hungry. He didn't eat. So what also could happen? You get underweight, you get malnourished, right? So you actually end up going to the hospital because you just felt so crummy, and they found out, like, dude, you got to cut off this medication, right? So again, it can be a double-edged sword, but again, for most patients, it's going to be a huge benefit because it will drop that weight. And some patients are just put on this for the weight loss, even if they don't have diabetes. So it could be an off-label use.
Which I don't, because there's like this like fat paradox in diabetes where like people that have more weight on them end up like living longer, and the individuals that are a little bit, I've read like a couple studies on it.
Okay.
It's like a thing.
Okay.
And so like like being that if that is true, then that would probably like I don't know decrease their life expectancy.
Did you guys ever see The Simpsons where they're talking about Mr. Burns, why he doesn't die, he lives so long? It's because like all the diseases are trying to get to the door at the same time, so they're all stuck. I wonder if it's that kind of situation or something. But I don't know. I haven't read up on that. It's interesting. But no, I mean, from a cardiovascular standpoint, like his blood pressure is under control, his lipids are under control. You know, so from that standpoint, the overall, by at least our objective measures, he would seem more healthy. But yeah, I'm not sure. I'm not familiar with that effect necessarily. You send me some a nice review article and I'll see about this fat paradox. Yes. Anyway, other big thing you can find is pancreatitis. Oh, sorry. Go ahead. Yeah. Typically no, right? So typically this will be something you may find if you maybe have a patient who's overweight but doesn't have diabetes. This may be something they try. So I'll see that in some cases because it is very, very effective, but it's very, very expensive on those cases. And again, insurance companies might not be as likely to cover it from that standpoint. But yeah, usually you're going to find this is going to be add-on therapy, right, to something like metformin. Okay. And do you have any other questions? No. Just getting the band started out there, but we only have a few minutes left. Anyway, the other big thing is pancreatitis, right? So again, this is kind of a characteristic thing. It makes sense because GLP-1 stimulates the pancreas. You could see pancreatitis develop from that. Okay, so just one thing to know. So the other three that we have nowadays, there's probably going to be a bunch more because it's kind of like a blockbuster set of meds here. Because again, actually super effective drug that drops weight. It doesn't cause your heart to explode. That's awesome, right? Because again, what do we have before that caused weight loss? Basically have to give them speed, basically, right? So either amphetamines or drugs that basically were stimulants that cause strokes and cause heart attacks, right? So now we have a drug that basically just stops you from wanting to eat, like much more effective and safe from a cardiovascular standpoint. So again, you're probably going to see a lot of these. But some of the big ones you may run into includes liraglutide, dulaglutide, and albiglutide. And the biggest differences here are how often they have to be administered. The half-lives are much better on these, and so you have to give them less frequently. So for instance, some of these are given once weekly, right? So if you said, here, inject this twice daily, or you can inject this once weekly, what are you going to go for? Once weekly, obviously, right? So every time. Yeah. So I think liraglutide you may be seeing used twice weekly. Yeah. Anyway, so then the other side you have the DPP-4 inhibitors. Again, probably not going to be as effective. These are actually around before GLP-1 agonists were around, but they will help to kind of increase levels of GLP-1 by blocking the breakdown of it, right? So we're helping our GLP-1 work a little bit better there from that standpoint. And so we have a couple of them here. We have things like alogliptin, sitagliptin. So if you see gliptin, you kind of know it's going to be a DPP-4 inhibitor. Saxagliptin and linagliptin. Again, not as effective, but it could be an alternative. And it's good as an oral agent if you didn't want to inject yourself with one of these GLP-1 agonists there. Biggest thing you can find as far as side effects go is some diarrhea, headache. Again, not as nearly as strong of an effect on satiety and on gastric emptying as you would see with like a incretin mimetic, but you will see some risk for anaphylaxis and angioedema, and there are some chances for skin manifestations like Stevens-Johnson's. That's another thing to watch out for. And again, looking at combination therapy here, either using sitagliptin by itself or say metformin by itself, or using combinations, you're going to find you get much better results on A1C than either by themselves. Okay, so again, this is another common combination you'll find, like Janumet, which is Januvia plus metformin. Oftentimes you're going to find they'll kind of make a portmanteau out of these drug names, and that's where they get the names from. So just to give you a comparison between the GLP-1 agonists and the DPP-4 inhibitors, just know that one, they're both going to help with insulin secretion. They're both going to reduce glucagon secretion. GLP-1 agonists obviously going to be more effective there. Looking at hyperglycemia should be reduced for both, right? Gastric emptying, though, is a big effect of the GLP-1 agonists, right? The satiety, nausea, vomiting, the appetite suppression, the weight loss, the pancreatitis, that is all going to be the hallmarks of the GLP-1 agonists. You're not going to see the same effects from DPP-4 inhibitors, okay? That's just one thing just to note with those. And again, as far as like safety goes, like Stephen Johnson's, let them know if you see any rashes, any blisters, anything like that. That's something you really got to worry about. You also can form some antibodies against the proteins of the GLP-1 agonist, so just know that could be a risk for anaphylaxis, just like with any other injectable product we've talked about.
Do you normally see DDT4s mixed with metformin, or only do you see with like sulfonylureas?
I would typically see someone who's starting on, and again, the general mantra is you're always going to start with metformin unless you have a contraindication. So more often than not, I'll see metformin plus a DPP-4 inhibitor, right? Or I'll see a metformin plus a sulfonylurea. So that's generally the flow of things typically. And again, I'll show you a table at the end here that kind of compares all of those. The last group we have here, let's cover this quickly, are going to be the SGLT2 inhibitors, okay? So basically, if you think back to your kidney lectures, or how the kidney's working, at the glomerulus, you kind of filter everything, right? So you filter amino acids, you filter glucose, you filter bicarb, electrolytes, all that good stuff, right? Now, does all of that make it into the urine? No, why? You reabsorb a lot of that stuff, right? The proximal convoluted tubules, you got to remember that. It's going to absorb a lot of that stuff, right? All that glucose, hopefully, is going to get reabsorbed. Otherwise, if it's not, if you have high blood sugar, it's going to come right out in the urine, right? It's how we used to check to see if someone had diabetes before we could check their blood glucose. Just taste the urine, if it was sweet, and you know, okay, I got a diabetic patient here, right? So, what if I could block the reuptake of that sugar and just allow it to go out in the urine? That should reduce blood glucose levels, right? Because I'm peeing all out, I'm not reabsorbing it. And what should I do to the weight? Probably should go down a little bit, right? You know, as severe as the GLP-1 agonist. But basically, this is what this is doing, right? It's blocking the reuptake of glucose in the proximal convoluted tubules, so you're just going to pee it right out. Now, based off of that, what do you think could be some of the side effects? Fungal UTIs, right? So you can actually see a bigger risk for developing fungal UTIs. And actually, 4 years gangrene was just something they said, FDA just came out with a recent warning, probably last year sometime, and said, hey, this is another big risk you can see with this, right? So again, it's effective, but you got to think about at what cost, right? Again, if you have a patient maybe has recurrent history of UTI, not a good drug for them, right? Because again, all that fungus and bacteria and all other stuff likes to chew up that sugar, just like it does anywhere else, and so that's where you run that risk.
So that study was just on Jardiance, right? But only because that's the only one that they picked. We don't know if it can happen with all the other ones, but
I believe it's been reported with the other ones, at least in the clinical trials. I haven't poured over every single trial, but you'll find that again it's a class effect, because again it happens to one, it stands to reason it'll happen to the others, and so the FDA will take that and say, well, we're just going to apply a black box warning to all of them, right? Potentially. Yeah, so I just assume it's all of them. Right, and maybe find one that may be a little bit better than the others, but it's probably less effective because again, mechanistically, it makes sense why that occurs, right? Yep. Yeah. So again, it's not. I mean, but some patients may be less prone to that. You know, maybe male patients less prone to it than female patients. We know females typically are more likely to get UTIs anyway. You know, it's just something with the anatomy that we know. So who can say, right? But again, these are brand new drugs. So talking 5-10 years from now, we may not even be talking about them the same way we are today, right? So again, as with all things change, right? Anyway, one thing I do know though is they have the most difficult or nerdy sounding names I've ever heard in my life. So canagliflozin. I don't know who came up with that. It is very difficult to say. Dapagliflozin. So anyway, so again, I think the brand names are a little bit easier. Invokana, Jardiance, kind of give them a nice, like, kind of more classy sounding brand name because the generic just sounds so goofy, right? Anyway, but that's what they're going to be doing, and you already know that they're going to lower blood glucose and lower the body weight as well. Okay. As we said, urinary fungal tract infection, 7 to 11%. So again, 1 in 10 patients you prescribe this may get a fungal UTI. Not great, right? Because again, you have a patient who comes in with a UTI. What's your first assumption? It's bacterial, right? So again, if you say you were working in urgent care of the ER, female patient comes up, they have a classic UTI, and again, when you are looking at those cultures or you culture stuff out, you're culturing for bacteria. Fungus is not going to show up on there, and so you get, okay, here's your Bactrim, here's your 1 double strength twice a day for 10 days, and they come back and like it's still happening here. You have to go through the history, look to see what they're on, because you just know that that's going to be a risk here, right? Fluconazole might have to be added on that regimen if you think it's fungal, right? It's something to consider there. Anyway, so things to look at. Other things you can find, hypotension, because again, you have all that extra sugar, all those extra osmoles in the urine. It's going to draw water with it, so you can see hypotension due to volume depletion potentially. Issues with calcium reabsorption, so there is bone fracture risk. That's one thing we saw with canagliflozin a little bit more. It's also interesting that you can develop this euglycemic diabetic ketoacidosis. You're like, how does that make sense, right? Well, again, if you're peeing out all that extra sugar, the blood sugar may look normal, but that doesn't mean you're getting that sugar into the cells for them to actually work, right? So that is another thing you may see somewhat rarely. So anyway, this is the table I want you to refer back to. Again, it seems like a lot of information, and it is, but it makes sense, right, if you go off of this. Look at the efficacy as far as the reduction of A1C. Look at the hypoglycemia risk. Look at the weight effects. Look at the side effects. Look at the cost. Now, again, this is why we like metformin so much, because it meets all those bills, right? It meets all those factors there. It causes neutral effects on weight. It's cheap. It has low risk hypoglycemia. That's why we like it as a first line. And then it's kind of dealer's choice what you move up to, right? So again, if they're overweight, maybe something like a GLP-1 agonist is a good choice, right? If they have a history of UTIs, maybe an SGLT2 inhibitor is a bad choice for them. These are all things you're going to have to consider, right? And these are good test questions because it could be like, patients on metformin, their A1C is still 7.5. What do you want to put them on next based off of X, Y, and Z? Okay, these are things I want you to consider. Anyway, and then obviously for a third regimen or a third, when you get to triple therapy, again, or insulin is always going to be the other option as well, right? So once you get two options, two agents on board and they're not working still, again, you got to ask the patient, are you being compliant? Are you using like you're supposed to? Is the lifestyle modifications in check? They're still having issues, then always consider either a third oral agent, the GLP-1 agonist, or insulin is going to be the other option there, right? Because again, at the end of the day, insulin is going to fix the problem. Because again, you may have patients who are extremely resistant, but I can give enough insulin to fix anyone. It just may take a whole heck of a lot of it. Okay, but again, why don't we like insulin? Hypoglycemia risk, weight gain, injectable. All right, so again, the host of reasons why we try to use that if we don't need to. Okay, that's the kind of the general flow of things for a type 2 diabetic patient. Always start with metformin unless they have a contraindication. Okay. Yes, ma'am.
So if they're type 2.
Yep.
They don't tolerate metformin because of constant GI effects. Could we put them on a GLP by itself?
Potentially.
Okay.
Yeah, so if they couldn't tolerate metformin, if the insurance was going to cover it, I can almost guarantee you, though, that they would try metformin. You would say, okay, here's your prescription for Victoza. They would go to fill that and then get a denial, right? And so they'd say, well, and you try to do a prior authorization, and they would probably say, well, you only tried one medication for that. Why don't you try other oral options first? Right? So that's kind of the thing, because again, it's a big ticket item for that GLP-1 agonist. So they would prefer to see that, hey, they failed 2 or 3 different drugs, and then they may give you the authorization to do so. Okay? So just because you write a prior auth doesn't mean automatically the insurance company is going to cover it. They're going to fight you tooth and nail. Because it's in their economic interest to do so. Okay? That makes sense. Anyway, so any other questions? I'm going to check the board real quick, and then I'll let you guys go.